Good afternoon, everyone, and thank you for taking the time to join us for this webinar. My name is Shanti Singh Anthony, the Knowledge Coordinator for PANCAP based at the PANCAP Coordinating Unit in Georgetown, and I'll be your moderator for today's webinar. Let me extend a warm welcome to you on behalf of PANCAP and the Director, Mr. Derek Springer, and thanks again for joining us. The region has committed to achieving the 90-90-90 by 2020, and in this regard, this series of webinars organized by PANCAP will facilitate discussions on the scientific evidence and best practices in the region. While it is great that we will share best practices and successful interventions, the webinars will also facilitate a greater understanding of the barriers, challenges, and gaps in the regional response, and moreover will propose recommendations for addressing these. With that as a background, a few logistic and operational points to note before we get into the presentation. Firstly, your mics are muted. If you have questions as the presentation progresses, please type these in under the question row on your panel. We will address them during the question and answer segment at the end. Secondly, in relation to the flow, we will take the two presentations, and this will be followed by the question and answer segment. Finally, the webinar will be recorded and shared on the PANCAP website for the benefit of the greater partnership. The last three webinars focused on the first 90. Commencing today, we're shifting focus to the second 90 of people living with HIV who receive antiretroviral therapy. This webinar is really very timely for two reasons. Firstly, as you're aware, UNAIDS has released its AIDS update report, and we're pleased that 81% of the people who know their status are receiving antiretroviral therapy. A closer look at the data, however, shows that this really translates to 52% of people living with HIV in the region receiving treatment. The bottom line is we celebrate our achievements, but remain cognizant that there is still so much more to be done in order for us to achieve the treatment goals of 90-90-90. Secondly, there has been some really exciting news and updates coming from the International AIDS Society Scientific Conference, including the baby from South Africa in remission. With this, I now transition to our first speaker, Dr. Malika Mootoo, who is a medical practitioner for the past 29 years and a pediatrician for 23 years. She's been managing HIV pediatric cases in Guyana from the inception of our epidemic. Dr. Mootoo is currently the program manager of Positively United to Support Humanity, PUSH, a key component of PEPFAR support to Guyana's HIV response. I now hand you over to Dr. Mootoo, who will take us through advances in pediatric HIV management.
Good afternoon, everyone. Thank you very much, Dr. Singh, for that great introduction. I'm going to speak to you very briefly today about advances in pediatric HIV. And I wanted to start, first of all, by just going through very quickly the pediatric HIV timeline, because I thought we would probably have a better understanding of how far we've come when we see where we came from. So in June 1983, the first reports of AIDS in children were documented. It was thought that this may have been as a result of casual contact, sharing utensils, touching each other, shaking hands. However, it was later concluded that probably these children became infected from their mothers, so that it was probably the first cases of mother-to-child transmission that were documented. In December 1984, Ryan White, who was a hemophiliac, became infected through a blood transfusion. In March 1987, AZT was approved as treatment for HIV, but it was only approved for adults. In the same year, in July 1987, WHO confirmed that HIV can be transmitted through breastfeeding. And October 1990, AZT was approved to treat children with HIV. So it took 3 years before it was actually approved for use in children. Things went a little quicker after that. In 1991, didanosine was approved for use in children with HIV. In August 1994, AZT was recommended to prevent mother-to-child transmission of HIV. 1995, lamivudine was approved for use. 1996, stavudine. 1997, protease inhibitors were approved for use in children. 1998 saw the NNRTIs being approved for use in children. That would be the first generation, which was nevirapine and efavirenz. In 2000, lopinavir and ritonavir, which is Kaletra, was approved for use in children. In March 2003, fusion inhibitors were approved for use in children over the age of 6. And in 2009, raltegravir was the first integrase inhibitor that was approved for use in children. So what's new in pediatrics? So I am basing this on the on a 2016 guidelines for the use of antiretroviral agents in pediatric HIV, and I'm just going to highlight a few things that have changed that I think might be of interest to us, especially us working in the Caribbean. The first thing that has changed is people first language, which I'll just say a few words about that. How we diagnose our infants, how we monitor the children who have HIV infection, what treatment regimens to use. There have been some changes in that, and then adherence to ARV therapy in children and adolescents, and then the management of children, focusing mainly on modifying regimens in children with sustained viral suppression, and then recognizing and managing ARV treatment failure. So the incorporation of people first language was something that came from the community. They thought that the way we said things was very stigmatizing. So people first language focuses on the person rather than the disease, and it recognizes the fact that language does empower individuals, and it helps to reduce stigma. So examples of language edits would be the use of, instead of saying HIV infected children, we would say children living with HIV, or children with HIV, or children with HIV infection. So the focus is on the children and not on the infection. So some of the things that have changed in the diagnosis of HIV infection in infants, as you know, and especially with all the news, the Mississippi baby and now the South African baby, the earlier we diagnose and the earlier we start treatment is really key in treating our children. So virologic assays, those are the assays that directly detect HIV, are what we are going to use to diagnose HIV infection in children younger than 18 months. And these are the children, of course, that have had perinatal exposure. HIV antibody tests should not be used in children younger than 18 months. Virologic diagnostic testing is recommended to be used at 14 to 21 days, 1 to 2 months, and 4 to 6 months. Virologic testing at birth is something that we have to consider for newborns who are considered to be at higher risk for perinatal transmission. And the children who would be considered to be at higher risk for perinatal transmission would be, of course, the infants born to mothers living with HIV who did not receive perinatal care, did not receive ARV drugs, neither antepartum nor intrapartum, or only received ARV drugs intrapartum. They were diagnosed with acute HIV infection during pregnancy. They had a detectable viral load going into delivery, and they may have received combination viral loads, ARV drugs, but they never sustained viral suppression. We can presumptively exclude HIV infection in non-breastfed infants if they've had 2 or more negative virologic tests, one at older than 14 days and one at older than 4 weeks. Or if they've had 1 negative virologic test at older than 8 weeks, or they've had 1 negative HIV antibody test at older than at six months. Definite exclusion of infection would be 1 test at older than 1 negative test at older than 1 month, 1 at older than 4, and 2 negative HIV antibody tests from separate specimens at older than 6 months. But I want to stress that even though we have both presumptive and definitive exclusion of HIV infection, you have to look at the child at the whole. And even though it is based on the negative tests, if we see any signs or symptoms that this child is not progressing well, then we need to reassess the child. Reassessing the child at 12 to 18 months by doing an antibody test to see if the child has seroreconverted is, of course, a very good idea, and it is highly recommended. I put this slide in here because of once the child is infected, it is recommended that at baseline we do CD4 and viral load, and that this should be repeated. If the child is not started immediately on treatment, it should be repeated every 3 to 4 months until the child is started on treatment. It is also recommended now that we do drug resistance testing in those countries where it is available at the time of HIV diagnosis. And then what do we start the children on? There have been some changes here and some new recommendations that have been given. For treatment-naive patients, it is strongly recommended, of course, that we use a 3-drug therapy. It is still strongly recommended that we use that, and that should include, along with a dual nucleotide NRTI backbone, we should have either a boosted protease inhibitor or an NNRTI inhibitor or an integrase strand transfer inhibitor. So one of the things that we'll look at here very quickly, I'm not going to go through this whole slide, is that the panel has recommended initially that we use nevirapine plus 2 NRTIs for infants between the age of 0 and 2 weeks. After 2 weeks, it is recommended that we change these children to 2 NRTIs and to a PI. There is at this moment no soundproof evidence to show us that it is better for the child to start treatment before 14 days of life. For children between the age of 6 and 12 years, dolutegravir plus 2 NRTIs has been added as a preferred initial regimen for children. Tenofovir alafenamide has now been added as a preferred NRTI for adolescents 12 years and older. Efavirenz and lopinavir plus 2 NRTIs are now classified as alternative rather than preferred regimens for children between the ages of 3 and 12 years of age. And twice daily boosted darunavir or raltegravir plus 2 NRTIs are now have been changed from preferred to alternative regimens for children over the age of 6 and below the age of 12. And this is just, the next 2 slides is just really lists of the preferred regimens and the alternative regimens. So, adherence to treatment. This is something that has plagued all of us. We all know that adherence to antiretroviral treatment is the principal determinant of virologic suppression. We know poor adherence to ARV drugs is the problem that we commonly encounter with all of our patients. There are a variety of factors that are associated with non-adherence. The taste and the size of the medication, the formulation, the frequency of the dosing, the side effects, the toxicities, the child's age and the developmental stage of the child, and also the caregiver. What is the caregiver's psychosocial characteristic behavior? What is the behavior? What is the psychosocial state like? How much does the caregiver understand about the medications and whether the medication should be given or not? So it is strongly recommended that we talk about adherence before we initiate ART, and we talk about adherence before we change regimens, and we talk about adherence and we assess adherence at every single visit that the patient comes to, and we keep looking for strategies to keep improving or to maintain good adherence. Apart from using the viral load to monitor adherence, we should have at least one other means of measuring adherence. And if possible, we should put our patients, especially our adolescent patients, on once daily antiretroviral regimens. Regimens with low pill burden have given us better outcomes. So these are some of the ways we can assess adherence. So we can monitor viral loads. We can do self-reports. Most of us do that in our clinics. We ask the patients, have you been taking your medications? Have you missed any doses? We know that we don't always get the correct answers here. So that might not be the other good way of assessing it. A good way of assessing it is to ask, adherence is to ask them to describe the medication that they give, when do they give it, what time do they give it, how many pills do they take. That might be a better way of assessing adherence. We always need to look at the barriers to administration of medication. Try to solve these barriers or resolve these barriers. We can monitor pharmacy refills. Have they come to the pharmacy to pick up their medication when they were supposed to come, or did they just walk straight out to the clinic? And then we can do pill counts. We can ask them, either announced or unannounced, to bring in their pills and let us count them. So viral load monitoring. This is one of the ways that, of course, we check for adherence. Many people, many experts recommend that we do it. We do viral load monitoring 2 to 4 weeks, but not more than 8 weeks after starting ART, and that is to assess for virologic response. It is a marker of response to ART because a fall in viral load suggests medication adherence. It suggests also that the medication is being administered in the appropriate doses, and that the virus is susceptible to the drug. Some experts will tell us to monitor viral load 2 weeks after starting treatment, because a significant decrease in the viral load after 2 weeks would be able to tell you that it has been taken properly, the dose is correct, and also that the virus is susceptible to the regimen that you have chosen. The modifying regimens is something, again, that has come up in this new guidelines, and it's an interesting concept, I think, for a lot of us. Children who have sustained virologic suppression on their current regimen should be regularly evaluated for opportunities to change to a new regimen. The new regimen should be one that is better for the child. Better because it facilitates better adherence. Maybe it simplifies the administration of the antiretroviral. Maybe it's fewer medications. Maybe it increases the potency of the antiretroviral. And most importantly, maybe it decreases the risk of drug-associated toxicity. If we are going to modify a regimen, and if we have past resistant testing results, then we should always consider those before we actually change the regimen. Initial regimens are always chosen based on safety, pharmacokinetic efficacy data for drugs. New ARV options are always becoming available for children. And as children grow, we also know that some things change with them. We may have initially started them on liquids. They can now swallow pills, and so we can change them from liquids to pills. And even changing to a new ARV regimen should be considered if we are going to change from liquids to pills, if we're going to reduce pill burden, if we're going to reduce the risk of adverse effects, and if we're also thinking of aligning regimens with adult regimens. Often changes to lower number of pills and less times of taking medications will improve adherence. Failure. Unfortunately, treatment failure is something that we all encounter with our clients. We all know there are 3 types of failure. There's virological, immunological, and clinical failure. But almost all ARV management decisions for treatment failure are based on addressing virological failure. When you are faced with a patient who has virologic failure, you should assess for adherence to therapy and also assess for medication intolerance. Many times the patient isn't taking the medication because it makes them vomit, it gives them itching in their mouth and itching in their tongue. They don't actually break out in a rash, but there is some intolerance. You also have to make sure that their prescribed dosing is correct for all the medications in the regimen, and that the medication is taken in the dosage that it is prescribed for the patient. We know that the main barrier to long-term sustained virologic suppression is incomplete adherence to medication regimens. And incomplete adherence to medication regimens are going to give us the emergence of viral mutations that is going to give either partial or complete resistance to one or more of the components in the regimen. We should, if we are able to perform ARV drug resistance when virological failure occurs, and we should do this while the patient is still on the failing regimen before we change them to the new regimen. Persistent viremia in the absence of detectable viral resistance to the current medication is a result of non-adherence. it is important to exclude other factors such as poor drug absorption or incorrect dosing. When we are going to switch a patient because of virological failure, we should be able to switch them to a regimen that should at least include at least 2, but preferably 3 fully active ARV medications with assessment of anticipated ARV activity. And this should be based on past treatment history and on the resistant test results. The goal of therapy following treatment failure is to achieve and maintain virologic suppression. When complete virologic suppression cannot be achieved, the goal of therapy is to preserve or restore immunologic function. Of course, we measure this with CD4 counts to prevent clinical disease progression and to prevent development of further drug resistance that could further limit ARV options. Children who require evaluation and management of treatment failure should be managed by a pediatric HIV specialist or someone who has a lot of experience in managing children with failures. This table here just gives you some options for your patient who has already failed treatment. If they, for example, if their prior regimen was 2 NRTIs plus an NNRTI, then you can change them to 2 NRTIs plus a PI, or to an integrase inhibitor, 2 NRTIs plus an integrase inhibitor. Okay, so what are some of the hurdles that we have? I don't like to use the word challenges because everything seems to be challenging these days. So hurdles, I use hurdles because I'm hoping that we will actually jump over these hurdles. So some of the hurdles that we have here is that our vertically infected children are living longer and they're getting older. That in itself is not a hurdle, but what is a hurdle is that many of them have already failed both first and second line treatment options because they've been on treatment now for 14, 15, 16 years. So there is a need for more child-friendly formulations, and this will include third-line and salvage regimens. And the child-friendly formulations, by that I mean a smaller pill burden. So if you have a child that is failing with 3 tablets a day, you cannot put them on 7 tablets a day. They're going to fail. Sure, they're going to fail. So we need things that are combination medications for the children, just 1 or 2 tablets a day that include drugs that they have not used yet. As they get older, we have to face lots of other problems that we didn't have to face before. The challenges of coping with disclosure. They have to disclose, they have to be disclosed to, and then they have to in turn disclose to their prospective partners. And then all of the adolescent-specific issues of education, employment, social security, sexuality, relationships, marriages, and parenting. A number of our young adolescent girls are now already parents themselves. We had to work through with them, the disclosure to partners. All of these challenges must be recognized. They have to be addressed appropriately at different levels, and we have to help to provide these children with an opportunity in life for a chance for a better future. That is the end of my presentation. As Dr. Singh said, there will be a chance for questions at the end of the second presentation. I thank you so much for your time.
Thank you so much, Dr. Mootoo. And again, if you have any questions, please type them into the question bar. At this point, I'd like to introduce to you Dr. Ruth Ramos, our second presenter. Dr. Ramos will be presenting on quality of care and monitoring quality of care. Dr. Ramos is a clinical practitioner for more than 20 years as well. She has worked with HIV for the past 15 years or so, and she is currently the director of Guyana's largest HIV treatment site that accounts for approximately 35% of our patient population, or about 1,500 persons on treatment. Dr. Ramos, like I said, will be presenting to you on monitoring quality of care and really making a case for clinical mentoring and supportive supervision, as has been the experience in the Guyana's program.
Good afternoon, everybody, and it's a pleasure to be sharing with you the experience that we have been having in Guyana. Thank you, Dr. Singh, for such an introduction. And we are talking today about our monitoring program and supervised visits. This has been an initiative of the National AIDS Program Secretariat linked to the HIV Treatment Working Group that meets quarterly at the national level as part of our quality care program, and is intended to ensure the quality of care or best practices, adherence to the national guidelines, proper documentation, and reporting all across Guyana. This chart here is just for you all to have an idea of our population. Guyana is a large country, territorially speaking, but with a small population, and our total patients care are somehow above the 5,000, 5,339. We have out of those 5,029 patients on heart, and the pre-heart population is just above 300. Our virologic suppression from the period January to June 2017 has been reported as 617 cases, and I just want to clarify that is this low number here apparently is because of the rate of patients that have been accessing treatment, accessing viral testing at this period of the year, but actually we have very good virologic suppression in the country. There are 22 care and treatment sites in Guyana. These are distributed among the 10 administrative regions. 9 sites are located in Region 4. This is the largest region in the country. So how we do this supervised visit? We have a team of experienced physicians that conduct visits to different treatment sites. There is a direct interaction with the healthcare providers at the site, doctors, nurses, medics, social workers, pharmacists, anybody who interacts with the patient. We discuss the difficult cases with the relevant healthcare worker, and we ensure that the updates on the guidelines are reinforced. 8 treatment sites in 2017 have been visited. 3 of these sites from the hinterland sent their charts for review in Georgetown, and a total of 323 charts have been reviewed, 295 adults and 28 pediatric charts. So what are we looking in this visit? One of the things is our chart reviews. In our chart reviews, we look for complete documentation. Documentation is very important because out of documentation, we have our reporting. Out of documentation is that we see if a patient has been managed properly. So we go from the general information about the patient to every single detail of physical examination. We notice when we go to the site is that still we're lacking somehow in documenting properly all the findings, especially taking proper address and contact of the patients, contact numbers, and that will definitely influence in the tracking the loss of follow-up. Follow-up visits is another aspect that is assessed, and this has to do how often the patient has been brought to clinic, if it's adequately with the period of the patient, is a new patient, a sick patient, a patient who is already on treatment for a long time. We assess the compliance of the patient to the follow-up visit that have been requested, if the patient have been offered the necessary counseling intervention to bring them those who have been lost to follow-up. We look for timely ARVs initiation, and that is regarding the clinical staging. Not so much now with the CD4 because our CD4 count right now has been increased to 500, and even we are extending to include everybody on treatment. So we need to know if these patients have been offered treatment and they have been initiated. We have to check also for the appropriateness of the ARV regime, the adequacy of the line of treatment, and if the physician have been able to identify treatment failure, if there have been adjustment in the presence of any toxicity. We look for the how laboratory test is available at the site, and if we monitor the patients correctly, laboratory monitoring, appropriate and timely request of laboratory investigation. We look for clinically monitoring if the patient has been assessed for TB, OIs, and if these OIs have been managed properly, if the patient has been assessed for cervical cancer. After we conduct the visit to the site, then we will have a meeting at the National AIDS Program Secretariat, and there we will do a debriefing of what transpired during our visits. So the full team will meet and we discuss our findings. We will make the observations, and we also share the achievement from previous visits. We look at the difficulties experienced by the staff and the patients at the site, and then the new challenging areas. The national program will identify the areas where assistance can be rendered and recommendations for interventions are made. A national report at the time is prepared. How then we move from there, we will disseminate the findings as we provide the sites with a report pertinent to their site, but also in a general way, we present the findings at the national quarterly feedback meeting where all the relevant stakeholders are present. Representatives from the PCT, National Public Health Reference Laboratory, the PNTCT, the Blood Bank, the Management Unit for the blood supply chain. Everybody will be there, and they will have an opportunity to respond to any issue that have been raised. Our mentoring program is an ongoing training that we conduct with physicians at the National Care and Treatment Center. That is the national reference site for HIV and other STIs. We have refresher trainings for physicians that have been already on the care and treatment. And we have training of the new physicians that are deployed to the hinterland or treatment sites on the different coastal area sites. What are some of the challenges or hurdles? As I was telling you, Guyana is relatively large with the population, and we have areas that are difficult with difficult access, and difficult access, and far areas also have an economical cost attached to it. So this is one of our challenges in reaching all of these sites. We have continuous loss of trained personnel due to rapid staff turnaround. I think this is a challenge throughout the Caribbean. Our doctors are deployed to the hinterland areas sometimes without any specific training on HIV and AIDS management. Now, how this, just to make a comment on how this supervision visit has made an impact. And we have a case of a specific health center that through the supervised visit, we identify issues on the site. This site was receiving only a physician from another site twice a month. So the patients were forced to see the doctors only on those specific dates. Laboratory has to be done only on those days. Sometimes the phlebotomies will not be available. So it was very limited. The patient will just see at one doctor. They will not relate to all the staff, and the staff at the site were not really knowledgeable about what was going on and how the HIV management too supposed to be conducted. So once we identified these issues, a plan was designed, and one experienced physician from the National Care and Treatment Center started conducting the clinics at the site, training the staff. He will do the labs. We will send a phlebotomist with them. The labs were done on the patients, so they will get updated on their function, renal function, viral load, etc. And a new physician was identified and was placed on the site. He was trained and mentored right there on site, and then later on this physician came and have a continuous training with us at the National Care and Treatment Center. Now, with our last visit, this site has shown greatly improvement. The patients are very well taken care of. They are doing well on their antiretroviral, and we are very satisfied with how the site is performing. So what will be our way forward? We would like really to continue and to increase the frequency of the visit to the site. We would like to include a comprehensive module of HIV at the medical school. We noticed that the new doctors comes out with just very basic knowledge about HIV, and we need them to be more knowledgeable about it. We train every physician. We would like every physician, before they are deployed to the different treatment sites or to the hinterland, to be trained specifically in HIV management. So this brings to the end to my presentation. We will appreciate it. If you have any questions, we will be most welcome to answer.
Okay, thank you very much to Dr. Ramos and Dr. Mootoo. I think we had two really good presentations. A lot of food for thought, and I'm happy that we have a few doctors who also joined us this afternoon on the webinar. So I see one person has their hand up, Florence Young, but I don't see a question. But I want to maybe start off with the questions to you both, Dr. Mootoo and Dr. Ramos. And I know, Dr. Mootoo, the emphasis that's always placed on adherence, because we want to make sure that our patients stay on first line and that we don't keep moving and shifting regimen. And it was really interesting because oftentimes I think as practitioners, we jump to the conclusion that patients are not taking their medication. But I'm really happy that you pointed out that the fact that there could be medication intolerance, because sometimes I think we jump to the conclusion or we become a little bit judgmental. But on that point, I wanted to get your take and to see whether you share the optimism that was shared at the International AIDS Society Conference about having putting the patient on, I think it's 2 weeks, and then switching over to a 1-month injectable. And I think that was particularly for adults. And what it did see is that there's been really great rates of viral suppression having somebody on a 1-month injectable. I know it's still trial, but I think it's really exciting news for the future. And so I wanted to have your reaction to that.
Thank you, Dr. Singh. Yes, I think for anyone who's ever taken medications, whether it's your daily multivitamin or your or any other medication that you have to take, the less times you have to take it, clearly the better for you. I think for many of our patients, if they have to come in once a month for an injection, I think we would actually see better adherence and probably better outcomes. Of course, there will be the odd person who even forgets to come in once a month for their medication, but I do think that that is actually something very promising, and I hope that it is something that we will be able to use, at least with our adolescent population. Injections with children are, of course, just a little, have their own special hurdles, yeah. But maybe with an adolescent population, I could see that working really well.
And I really like the point that you made about addressing some of the other issues surrounding adolescents, because indeed our population has been living, the adolescent population have been taking medications from almost since birth. And so a lot of them did move from first to second line, and so there is that need to move to think about really good third line that's efficacious but would also assist when it comes to issues like adherence. But my second question to you particularly, Dr. Mootoo, is in relation to the recommended 2 to 4 weeks viral load testing for monitoring post-initiation, because I know that WHO is recommending, and this is based on the evidence from resource-limited settings, that your first viral load testing should really be 6 months post-initiation. So I know that a lot of clinical practitioners are, thinking 6 months it's too late, and so we need to really understand what's happening. That's the first question. And the second question is, I know that a lot of clinical practitioners have the preference of having a baseline viral load before initiation. So I wanted to get your take on that, because I see that you're presenting that many of the experts are saying 4 weeks post-initiation?
So I personally like an idea of having a viral load earlier. I think for many times I'm not necessarily looking for total suppression, but I'm looking to see that there's been some drop in the viral load. For some of the children, we still do baseline viral loads when they come into care, and then we could see whether it is working for them or it isn't working for them. We have actually seen with some of our clients who we've done a viral load earlier, maybe at a month or 6 weeks after initiation, we've actually seen them suppressed, completely suppressed at 6 weeks, and some of them at 4 weeks. So that actually helps everyone when you get that result. It helps the patient because they feel like, well, this medication does actually work for me. It helps you because, one, you know you've chosen the right regimen, you've known you've chosen it in the right dosage, and the virus is susceptible to it. So it does give a lot of information. We have actually had patients as early as 3 weeks that have been virally suppressed.
Oh, excellent. Right. Thank you so much. And I wanted to finally ask you if you can share your thoughts and ideas on the South African baby. I know it has been the third one, and so there's a lot of excitement around this third baby,
yes,
right?
yes.
And it's all around babies. It's
yes.
all around your passion and up in Ramos' passion. But yes.
So yeah, it's exciting because this is the first. This baby has been actually undetectable for 9 years off medication. So this is actually a huge breakthrough. And I think studying this baby and studying why this baby has been suppressed for so long without treatment after initial treatment for a few years, I believe, or a few months, to find out why it is that, how is it that this baby could have been suppressed. I think for me, the excitement is also that I see this as a possibility for a vaccine or for some other type of medication that's actually going to help us, quote unquote, cure this disease.
Right.
And I find that very exciting.
Yeah. And now that you're talking about a vaccine, I'm wondering whether one of sort of the immediate benefits of this could be a faster elimination of mother-to-child transmission.
Yes, of course.
Yeah.
Yes.
Yeah.
Yes.
So, great. So I have one question to you, Dr. Ramos. I really appreciate the work that you do with the supportive supervision and the clinical mentoring. And I wanted to know, in terms of the monitoring of quality of care, are there other aspects of the program that really contributes to addressing quality of care? Because I think you did share the example of some of the documentation challenges that you have. Some of the other challenges around monitoring and so forth, and we've heard from Dr. Mootoo that one of the biggest issues that we face in our program is adherence, and I think a lot of it is also linked to the quality of care and how we deliver that quality of care. Are there other aspects that we need to really tie together so that we can truly have a good package that delivers the best quality of care?
Yeah, there are other aspects that the program is taking into consideration to monitor what quality of care are we giving to the patient. And one of them is the health qual, or the HIV qual, but I think we call it health qual, and that is where we go and monitor for every site how they are compliant with the guidelines. So we check registers, we check how the patient have been monitoring, how degree of virologic suppression we have achieved, how many patients have been initiated on treatment, and that gives us that general view of how the program is moving. We are trying to achieve our goals of the 1990. So we want to identify, so we work in BCP, trying to make accessible most testing across the country. So we try to get the people to know the status, we try to get the people to report into care, and those who enroll into care, we are urging every site to start them on treatment. So the health quality help us with that. Also, we have different surveys that we do among our HIV population. We have the client's satisfaction survey that will also help us to evaluate the program, how effective have we been in reaching to them. So I think about these two important aspects of the important aspect. And the PNPCP also is another very important aspect in our management, because if we are not having a strong PNPCP program, then we're going to continue having HIV positive infant, and then we will not achieve our elimination.
My final question to you, Dr. Ramos, before we wrap up is, I suspect that you probably have some guideline or some tool that you use for conducting your supportive supervision, and if you do, is it something that you're willing to share with PANCAP partners in the region?
Yes, I think our main tool is that we are using our guidelines, and then, as I was telling on the presentation, we are targeting according to the goals that we have to achieve to get our patients stay into care, virologic suppressed. So we assess our amount of patients that are being initiated, early initiation or adequate initiation, how many of the patients are being kept on care, if they are in the adequate treatment regime. So we could share the guidelines on the topics that we are checking when we do our supervised visits.
Okay, great. Okay, great. Thank you. So I'm going to give you both the opportunity to maybe make one final pitch in terms of pediatric management and quality of care. Yes. So maybe I can start with you, Dr. Mootoo. And Dr. Ramos, feel free to make a pitch for pediatric management too, because you've been so engaged in pediatric management. It's just that you're presenting on quality of care today. Yes.
So I think the pitch that I would make is let's try to detect HIV as early as possible in our children. Let us try to put them on the most appropriate regimen for them. Let us push and lobby for drugs that are combination, that are smaller amounts of medication with maybe just once daily dosing for our children, so that we can have better adherence. And for the children that have already been on medication for a while, our adolescent population, our babies that have grown up, let us help them as much as possible to achieve all that they can achieve in their lives, to have healthy lives, and also to help them through all of the hurdles that they will encounter being adversely affected children.
Dr. Ramos?
Yes, if I would like something very specific to stick out of this presentation is the importance of documentation. I think documentation is paramount. And as physicians, we tend not to like documentation. If we don't have the right information on the patient, we will never be able to track the patient. If we don't have the right entry of our interventions, we will not know if we manage it properly this patient. If we don't order and monitor the patients properly, then our patients going to fail, and we have toxic effects from the drugs. So please do the best in having your patients monitoring as clean as possible with all the information that will help you and help the patient in the future.
Okay. Thank you very much, Dr. Ramos and Dr. Mootoo. This brings us to the end of our webinar. On behalf of PANCAP and the director, Mr. Derek Springer, and all of the participants today, thank you again very much for investing in the webinar, sharing your knowledge and your experience with the partnership. Thanks to all of you for joining us. As a reminder, the webinar will be recorded and posted on the PANCAP website. Please do join us for our next webinar. This is a special webinar that's scheduled for Friday, this Friday coming. And it will be a live demonstration of the PANCAP website, the PANCAP redesigned website. This will be hosted by our PANCAP director, Mr. Derek Springer. So please do join us. Finally, I want to encourage you to stay engaged with the regional response with the partnership. Follow us on our social media platforms, Facebook and Twitter. And thank you again, and I look forward to seeing all of you on Friday. Before I go, you will receive in your email boxes very shortly a very brief questionnaire to gauge your satisfaction with the webinar. Please do respond. It's about 6 questions, not a very lot. And I look forward to seeing and talking with you again at our upcoming webinars. Thank you very much and have a great day.